Well, hello everyone. I'm Keith Martin. I'm the Managing Director of the Centre for Eye Research Australia and Ringland Anderson Professor of Ophthalmology at the University of Melbourne. And on the eve of World Sight Day, I'm pleased to welcome you to our Hope in Sight online forum. So thanks very much for joining us. So before we begin tonight's proceedings, I'd like to acknowledge the Wurundjeri and Bunurong people of the Kulin Nation, the traditional owners of the land where I am now, and I pay my respects to their elders past, present and emerging, and to their families. So one of the things that attracted me to move from the UK a few years ago to take on this role at CERA was the opportunity to help move on some great research that happens in our labs at CERA right through to clinical trials and ultimately to provide new treatments for patients. And so I'm really excited to introduce to you some of our team tonight. But before we get into that discussion, I'll hand over to my colleague, Associate Professor Peter van Wijngaarden. So Peter is CERA's Deputy Director, and he also leads our ophthalmic neuroscience group. And Peter and his team are developing cutting-edge new imaging technology to help detect conditions like Alzheimer's disease using a simple scan of the eye. He also has a strong research interest in diabetic eye disease and is Clinical Director of KeepSight, the National Programme for Diabetic Retinopathy Screening. So Peter, over to you.
Thanks very much, Keith. And I'm thrilled that so many people have joined us online tonight. Of course, we'd hope to be able to meet you all face to face this evening, but nevertheless, we're grateful for the opportunity to share our latest research with you. I have to say a big thank you to all of you who've shared your questions with us already. We'll attempt to answer as many of these as we can during the next hour. If you've not yet sent your questions in, please do so. You can do so via the questions box at the bottom of your screen, or you can post a comment on Facebook and we'll do our best to answer those. We do have a question and answer session with our panelists in the final part of the evening's proceedings, and we'll endeavour to address those. But for the questions that we can't get onto tonight, we'll reach out to you after the event with an answer. I have to note that we can't provide specific medical advice to you in this forum. If you do have a pressing personal question about your own care, I'd encourage you to consult your optometrist or ophthalmologist with those questions. Now, many of you will have seen the promotions from CERA for our Hope in Sight Giving Day, which this year is raising much needed funding for our cellular programming team that's led by Dr. Raymond Wong. And in a moment, Keith and Raymond will be joined by Dr. Tom Edwards, who leads our retinal gene therapy unit. And together they'll be discussing their research to develop new gene therapies for eye disease. But first, let's hear from Ray about some of the work that's underway in his laboratory.
The retina is a thin layer of cells at the back of the eye. It's responsible for detecting the light that we see and converting it into electrical signal, sending it to the brain to interpret it as an image. My lab looks at using stem cell technology to regenerate the retina, and hopefully we can utilize that to help patients restore their vision. A typical day usually includes working in a lab with human cells grown in the dish, and we store them in an incubator that allow us to test our technology and develop new treatment. Using this model, we can use stem cell technology to develop human cell culture that we can start growing in the lab, and that provide a resource for us to work with them and understand what's wrong with them in order to develop new treatment options to help the patients. The major motivation for me is the potential of our research to really help patients with vision impairment to improve their life quality and improve their vision. I think that really is the key for me every day, waking up knowing that I should be working hard in order to progress the research, because we do have a potential to make a difference to the patients and really help their life.
So I hope you enjoyed that behind-the-scenes look at Ray's lab, and I'd now like to welcome Ray, who, as you saw, is Principal Investigator of CERA's Cellular Reprogramming Unit, and also Tom Edwards. Tom Edwards is the head of our Retinal Gene Therapy Research Unit, and I'd like to invite them both to join our first discussion. So welcome, Ray and Tom. Now, I know that many of you in our audience tonight will be familiar with inherited retinal diseases, but Tom, for those who aren't, can you give us a brief outline?
Yeah, of course, Keith. Well, inherited retinal diseases are just that. They're inherited, so they have a genetic basis. And together, they together are the most common cause of vision impairment or severe visual impairment in working-aged adults. So whilst each individual gene that causes an individual inherited retinal disease may on its own be rare, grouped together, inherited retinal diseases produce a significant impact on our community, and obviously for any one patient with an inherited retinal disease, there's a possibility of vision loss over the course of their life. It can vary from, in the severe cases, onset in childhood, and in other cases, onset in middle age or older age. The reason we're interested in them is from a genetic point of view, they're relatively simple. They're all caused by a single gene spelling mistake. And so from that point of view, they can be targeted with gene therapy strategies. The other reason, of course, we're interested in them is they currently don't have a cure by and large. And so that's a great challenge for us and a worthwhile pursuit for our research teams.
That's a great answer, Tom. And I guess until recently, one of the frustrations with ophthalmology has been having to tell patients with inherited retinal disease that there's nothing we can do. You know, that's what we've all been doing throughout our careers up until very recently. And it's amazing that that's now starting to change because of, you know, the gene therapy treatments that are starting to come through. So Tom, with your clinician's hat on, how do you see gene therapy research impacting on patient treatment in the future? What's going to change, you know?
Yeah, well, it's a great question, Keith. I'm always conscious of not sort of raising expectation too much. I don't want to provide sort of false hope, if you like, but there is hope. And that's the exciting thing. From the earlier stages of my interest and involvement in this field, I was sat in lab meetings discussing preclinical, laboratory-based assessments of potential future gene therapies in a situation where you're looking at cells in a dish. And now some of those treatments, I'm getting contacted, can we do the clinical trial for that treatment? Have you got patients or participants who would be interested in a clinical trial of that treatment that a few years ago I saw being discussed and talked about in a purely laboratory setting? So I'm hopeful, and I think it's exciting, and we're really just right at the very beginning of this genetics revolution. And fortunately for our patients, ophthalmology is right up the front of this transition. And I think perhaps in the future you might have patients come in and you do their genetic test and you find out what gene has caused their eye disease, and then you're like ordering a lens for cataract surgery. You might be dialing up the particular gene therapy for that particular person and booking them in for theatre. I mean, that's not unrealistic to think that that's a possibility in the future. I think we're heading that way anyway. So it's an exciting time.
Yeah, Tom, that's a great overview as well. And you know, one of the things is that you've spoken about, you put it beautifully, the spelling mistakes that are the problem when there are single gene defects. But Ray, you're trying to develop treatments for when the whole book is missing. You know, when the cells have actually gone and there's no message there at all. But you're using gene therapy to reprogram one type of cells into another type of cells, which sounds like alchemy in a way, sort of biological alchemy. What is your sort of take on the difference in your approach, and why might it be suitable for some types of disease where Tom's approach may be less able to bring back vision?
Yeah, sure. So in a traditional gene therapy approach, like Tom mentioned, I guess the approach would be looking to replace or fix the faulty gene that is causing the inherited retinal disease. And this is a good strategy that can work, but the limitation there is we know there are many genes that is causing inherited retinal diseases, up to more than 150, and more than 60 genes causing retinitis pigmentosa. So that would require development of many different gene therapies in that sense. And I think in this case, regenerative medicine is a really attractive strategy for this to regenerate the retinal cells that are lost so that we can improve or restore vision in the patient. And we think cell reprogramming technology is a key in this. So cell reprogramming technology is really a Nobel Prize winning technology that allow us to turn one cell type into another by switching on a set of genes. In recent years, we've seen a lot of research that shows cell reprogramming can be applied to regenerate different tissues in preclinical models, such as the heart and the pancreas and so on. And so this is really an exciting time to work with cell reprogramming technology. And our research is really aiming to apply this cell reprogramming technology in the eye. In particular, we are looking to develop a gene therapy that can stimulate the stem cells within the retina. These are the Macular glial cells, to regenerate the photoreceptors. These are the light sensing cells that are lost in many retinal diseases. I think the key advantage of this approach is that we should be able to treat a range of retinal diseases if this works, that are characterized by photoreceptor loss, such as retinitis pigmentosa, regardless of the genes that is causing it, and potentially AMD and Stargardt disease as well. So we're very excited about this approach.
Ray, that's very exciting, and I think the potential of this strategy is amazing, and it's going to be great to watch it develop over the next few years. Tom, you're one of these crazy people that tries to combine being a sort of practicing clinician and a busy surgeon with developing new treatments in the lab. So can you tell us a bit about what that's like and what your life is like in that way?
Well, that would make two of us being crazy, Keith, and I'll try to some extent emulate what you've done with your impressive career. But yeah, you're right. I mean, it's a balance of seeing patients like in a usual normal setting in a clinic, through to seeing more specialized groups of patients in a genetics clinic, where they'll have an inherited retinal disease, and we're trying to get to the bottom of the potential causative gene. And then most of those patients are very interested in research, and that's where I've been fortunate to team up with Professor Lauren Ayton, who you'll have the opportunity to hear from later. And we have this natural history study that's looking at trying to understand a lot of these inherited retinal diseases in greater depth. And from that cohort of patients who are interested in research, we're then choosing genes that are most, I guess you could phrase them as the low-hanging fruit, those genes that are amenable or most amenable to a gene therapy strategy. And one of the diseases we're looking at is called Beatty crystalline dystrophy, and we're at the late stages of testing a potential treatment for that disease, and we have others in the pipeline. So it's always a balancing act of seeing patients, and then in the lab I have a fantastic team led by a postdoc called Dr. Sloan Wang, and he's developing a lot of these laboratory techniques, and together, it's really a team that I'm a part of. I wouldn't necessarily ever take the credit of doing it myself at all, but I'm fortunate to have a great team around me.
Great.
Oh, yes. Now, sorry, to lead on then, Keith, to ask you. Yeah.
I'm just reflecting on the different ways that we can use gene therapy. This technology is really just a way of sending messages to cells in a language that they can understand. And Tom, you've been correcting messages where there's a spelling mistake, which makes the message not make sense. And Ray, you've been sending messages to cells to get them to recapitulate something that happened in early life, but that we've lost the ability in terms of producing new types of cells or switching one type of cell into the other. And what I'm doing with glaucoma is sending messages that help cells to look after themselves, to protect themselves. In other words, with most glaucoma, there's not just a single gene that's missing, but the cells that make up the optic nerve are more sensitive to damage, and so what my type of gene therapy is doing is helping those cells produce protective factors that make them more resistant to injury, so toughening them up, and such that they're more likely to survive in glaucoma for longer and therefore preserve vision for longer. And that's something that we're working very hard to get through to the clinical trial stage as well. So all of these treatments are really moving towards the clinic. I think that's the really exciting part. We used to talk about this as if it was science fiction not too long ago, but it's really coming to a clinic near you before too long. So just to round up this section, so what's the next stage? I guess I'll start with Ray and then Tom. So what are the next steps that you're going to be doing, and how long until we see your treatments coming through to clinical trials?
Yeah, so we're still at early stage, but we have made some very exciting progress. So recently we have created the most detailed human retina gene atlas, which really tells us the genes that are present in major cells within the human retina. This really helps us identify the genes to switch on in order to regenerate photoreceptors. And based on that, we have developed a cell reprogramming technology to turn human retinal stem cells, these are the Macular glial cells, into human photoreceptors in a lab dish. So the next step for us is really to translate our cell reprogramming technology into a gene therapy and test the safety and efficacy of our treatment in other preclinical models. Now, typically, research is a rather slow and rigorous process, so this could take 5 to 10 years before we roll it out to clinical trial. But with your help and your donation, we can really hope to accelerate our research so we can bring our treatment to the clinic as fast as we can.
Great, thanks, Ray. And Tom, just to finish off?
Yeah, I mean, we're ready to go with a clinical trial, really, for our sort of flagship project for BAT crystalline dystrophy, which is an inherited retinal disease. So we're good to go, and it's just a matter of really getting the funding together to do the phase 1 clinical trial, which is a big step up in the funding required. But it's an exciting time for us and an exciting time for our patients.
Great stuff. Okay, so thanks, Tom, and thanks, Ray. So we've heard about what's happening in the lab, but equally important, I think we need to understand how various types of eye disease impact on people's lives and how we identify possible participants for future clinical trials. So before I hand over to Peter again, I'd like to share with you a short video about our natural history study of people with inherited retinal disease.
One of the main parts of my research is making sure that we understand the natural history of inherited retinal diseases. So we really want to know why these conditions develop and how people lose their vision over time. And so we're getting people in to learn more about the diseases. And at the same time, that's allowing us to get a database of people that are interested in our research. So what is happening now is that new treatments are coming up for blindness all around the world, and we need to find people very quickly once we get a treatment on our doorstep. So our role here is to develop a database of patients that are completely ready to go. A typical day in our lab is quite varied. So some of our group work on clinical trials, so things like gene therapy investigations, and they might be seeing trial participants, getting them ready for surgery, or assessing how they've gone after a treatment. Other people in my lab are working more in the research projects around inherited retinal diseases. And so again, that can involve working with participants to look at their eyes, doing examinations, giving surveys and other aspects like that. Our lab also do a lot of publications, so we often spend time writing up our results, and we're also very interested in learning more from people that have lived experience with inherited retinal diseases. So our natural history study has now grown to over 120 participants, and we've collected information on their clinical data as well as their genetics and some questionnaires about how they feel about their eye condition. We're involved in running a clinical trial in gene therapy for a form of age-related macular degeneration, and also a clinical trial that's helping people with Usher syndrome. And there's a number of other trials on the horizon. So it's been a very exciting couple of years, and we're really looking forward to the future.
Fantastic. So for the next part of our discussion, I'm delighted to welcome Associate Professor Robyn Ayton, who was featured in the video. Robyn leads the Vision Optimisation Laboratory at the University of Melbourne and is an honorary researcher at CERA. And we're also delighted to be joined by Professor Robyn Guymer, AM, who leads our Macular Research Unit and who's my fellow Deputy Director at CERA. Welcome both.
Peter.
So, Lauren, we just heard about your natural history study and its importance at enabling study participants to access new treatments as they become available. Could you tell us a little bit more about how the involvement of study participants helps to advance your research?
Yeah, for sure, Peter. So Tom's given a fantastic introduction to what really our aims of our research are. So it's almost two arms to what we're trying to do. We're trying to learn more about the particular types of inherited retinal disease and what the natural progression of those conditions might be. But at the same time, we're also trying to learn more about what types of people might be eligible for these upcoming treatments. And so what we're hoping to do is have a database of people where we know what their vision is, we know what the gene affected in their particular condition is. We also know whether or not they're keen to be involved in some of these emerging treatments. And so we're really excited. The natural history database is growing really quickly. We've got people involved from all around Australia and New Zealand. And it's really helping us to progress the research and try and find out more about these conditions.
Fabulous. Lauren, it sounds like a really exciting time in inherited retinal diseases. How has the approach to these diseases changed in recent years?
It's changed a lot. I think both Tom and Keith really mentioned that the clinical aspects, whereas a few years ago, there really was no options for these people in terms of treatments. And now we have all of these exciting things on the horizon, and you've heard about them from Ray and Tom and Keith. And so now it's a really different playing field. So all of a sudden, we're really looking to learn more about these conditions so that we can potentially treat them. So that really has flipped the way that the research space is working in terms of IRD. The other big change really has been the advances in genetics. So in the 80s, we knew there was a handful of genes that could cause these inherited retinal diseases. And we now know of over 300 genes that can do this. So that's a huge increase in knowledge in only a few decades. And so what that means is what used to just be termed retinitis pigmentosa, and a big umbrella term for all of these conditions, can now be broken down into more specific subtypes of disease. And so what our natural history study is trying to do is learn how those different subtypes develop and what that might mean for the people that have them.
Fantastic. Thanks, Lauren. It's great to see CERA really at the cutting edge of this exciting field. Robyn, I'd like to turn to you now and try to get an understanding of how the natural history of age-related macular degeneration has been important for your research.
Thanks, Peter. So in AMD, we know that 1 in 7 people over 50 have some of the early signs of this disease, but not everyone progresses to vision loss. And so to try and understand through natural history studies who is more likely to progress to vision loss is very important. And so if you study people early on in the disease and then follow them until some unfortunately progress and some do not, you start to be able to have a look at what are the risk factors. And in AMD and in all retinal diseases in particular, the advances in the imaging of the back of the eye has meant that we have a much better understanding of all the sort of subtle nuances of what's going on in the eye. You can pretty much get almost a histological view of the retina using our new scanning techniques. And so through that, you can start to look at subtle differences over time. And so we've been very fortunate to be able to document what happens early in the disease to try and make it more plausible to intervene in this disease, in particular AMD, early. At the moment, the treatments wait until vision is threatened, primarily because if you start early, there's very limited ways of finding out whether you've been successful. But now, knowing what the natural history is, it's much easier for us to be able to intervene early and say whether or not a treatment has slowed down the progression.
Fabulous. That makes a lot of sense, Robyn. You alluded to novel technologies like improvements in imaging. We've also heard quite a lot about artificial intelligence. Could you tell us a little bit about the impact of these new technologies in the field of macular research?
So if we go back to sort of original trials where you have people with good vision and you introduce a treatment and you're wanting to know whether or not you've stopped like massive bleeding at the back of the eye or cells dying, you could see that on a examination or on a coloured photo. But now what you want to do is see subtle changes. And so imaging has enabled us to do that, but there's so many things to look at. It's almost impossible for a human reader, a grader, to look at an image and find out all the subtle changes. We do that, and it takes a couple of hours to look at each image to do it properly. But with artificial intelligence, we hope that we can train machines to how to read these images for us. And this has been a huge advance in retina. And in fact, again, ophthalmology leads the way often in artificial intelligence. So we've been using AI to train models to find these risk factors in AMD, just looking at an image taken from an eye. And it really reduces the amount of time and cost then for perhaps a drug company to undertake a clinical trial. If you can run an algorithm through hundreds of patients' images and come up with an answer in seconds or minutes rather than hours, that's a huge advantage.
Fabulous, fabulous. Robyn, clearly you're at the sort of cutting edge of AMD research and a world authority in that field. And I'm sure that many people online are wondering how they might be able to get involved in your research. Could you just give us a brief overview of some of the research that you have in progress and how people might get involved?
Thanks, Peter. So again, like all our other speakers, it's a very exciting time in AMD because there's a lot of new trials. So most of the viewers will probably, if they're interested in AMD, will know that there's been huge success over the past 2 decades in treating the wet form of macular degeneration where there's bleeding. There are still trials looking to improve the treatments, but most of the excitement is in trying to find a treatment for what's called dry AMD, where cells die, and currently there is no treatment for that. So at CERA, for example, we probably have 5 or 6 different trials looking to slow the progression of what's called geographic atrophy or dry macular degeneration. And our own research is really looking to slow the progression from the earlier stages to those late stages. So pretty much there's something for most people with AMD. So I would recommend people look on the CERA website, ask their eye care clinician to contact us directly if they're interested in research, because we pretty much have something that fits in to all the stages of AMD in terms of treatment trials. And if not, potentially there would be the chance to help us with our natural history studies where we learn about the disease by people giving their time to come into our research.
Thank you very much, Robyn and Lauren. Next, we'll go on to discuss about taking insights from the lab and clinic to develop treatments and then test them in clinical trials. And by way of introduction, let's see an overview of Tom Edwards' quest to develop a new retinal gene therapy.
Telling anyone that they've got the possibility of losing some or all of their vision over their lifetime is a tremendously devastating piece of news to communicate and for patients to come to terms with. But the exciting thing is that we now are seeing treatments coming online through clinical trial phase, preclinical work, and indeed the first FDA-approved gene therapy for a particular variety of retinitis pigmentosa. So it's in some ways an exciting time to be working in this field, and it's nice to be able to give patients some hope that there are treatments on the horizon. Our laboratory are working on developing cures for inherited retinal diseases with a basis in gene therapy.
We have done just about all the preclinical work that we can do on a particular treatment that we've been working on for the last few years that targets a specific inherited retinal disease. And we're now at the stage where we'd like to do a clinical trial.
I'm very lucky to be working in this area. It's an exciting field and one that I feel has a lot of promise and potential to save the vision of patients who are affected by these diseases.
Thanks, Peter. That was a great conversation. So for the final part of our discussion tonight, I'm again joined by Dr. Tom Edwards and also Dr. Carla Abbott. You haven't met Carla yet, but Carla is a research fellow in the Macular Research Unit and also with the Bionic eye team. So she's an optometrist by training who runs both clinical and preclinical studies to investigate the underlying causes of retinal disease and potential new treatments. And welcome, Carla. So
very much.
So Carla, you were recently part of a clinical trial of the 2nd generation Bionic eye, and many of our viewers today may have seen some of the publicity recently because you featured on A Current Affair, and there was a lot of other publicity on TV and other media around that time. Can you tell us a bit about that project and the impact it's had for participants?
Yeah, definitely. So it has been a big year for us. We've recently finished our second Bionic Eye clinical trial and have had some media coverage of that recently. The overall goal for the Bionic Eye device is to improve navigation and the ability to locate objects. So participants in the trial were people with light perception vision. So this means that for many years, they've had no ability to see objects, either with their central or side vision. And the key feature of our device that differentiates us from others is the very safe surgical approach, where the device is positioned behind the retina, involving a very simple surgery. So the trial was primarily a safety trial and very successful in this regard, as we had no serious adverse events over the 2 years of follow-up. So ultimately, we could conclude that the implantation of the device is a very safe procedure. And furthermore, participants were all able to use the artificial vision provided by the device to successfully locate and navigate obstacles, as well as perform common activities of daily living in their home environments. So a couple of the key things participants told us during the trial was that it enabled them to know when other people were around, including knowing when there is a shop attendant present at a counter, realising there are people mingling on a balcony, and realising when people are walking in front of them in a shopping centre. They also reported success in basic activities such as sorting light and dark clothing, finding their own letterbox at the end of the driveway, and identifying obstacles in the street such as poles and traffic lights and trees.
Wow, so it must be such a huge thing for people who have had virtually no vision for so long to actually get something restored. And it's incredible that you were able to help them sort of navigate and perform some of these tasks as well. It's just amazing. I guess the relationships with the patients in these trials are really important. It's a long haul when you're enrolling in a clinical trial, and it's a long haul until you get to the end. And I don't know, can you talk a little bit about the contribution that the participants made to the trial and how that relationship was managed?
Yeah, definitely. So, of course, we can never undertake such a trial as this without our wonderful participants and the impact that they make. These people have all opted to undertake the trial for altruistic reasons and to try and improve the visual outcomes for people with end-stage inherited retinal disease for the next generations. We do develop a very close working relationship with the participants as they become part of the research team, really, over the trial, which included 2 years follow-up after the device was implanted and turned on. And we've actually run 2 trials now with Generation 1 and Generation 2 devices, and the participants' willingness to try the device, open themselves to learning and new experiences, and to share their experiences with us as they started to integrate using the device into their home environments has been really amazing. So as well as the long days of testing, they've also been very helpful in device development as we work towards commercialization and producing a device that can go through the regulatory approval processes and become available to patients in the future. So we really are indebted to all the participants for their involvement over many years, and it's been a great experience really to work with all of them.
Thanks, Carla. It sounds absolutely amazing. So Tom, just back to you again. We've heard a bit about your work developing a gene therapy for inherited retinal disease, but you've also been involved in some of the recent trials of gene therapy for dry age-related macular degeneration. And you were telling me earlier on today that you've treated 7 patients now with a gene therapy for dry macular degeneration, which puts you right at the forefront internationally. Can you tell us a little bit about that work?
Yeah, of course. I mean, to echo Carla's comments, we simply wouldn't be able to do this research without the participation of the patients. And we wouldn't be able to know who the patients were it not for the natural history studies that Professor Guymer has been doing over all these years. So we really hit the ground running when we first found out about this project, because we already had this extremely valuable database of patients who we could invite to come in and screen for the study. So that really gave us a great head start. The surgery involves injecting a very tiny volume of a colourless liquid which contains the viral particles, about 0.1 of a mil, underneath the retina, near the macula, right near the macula. So we're actually causing a little localized retinal detachment in that area when we inject the virus under the retina. The next day, it's all been absorbed by the cells, and the virus has done its work delivering this particular gene, which is predicted to influence the progression of geographic atrophy, to slow it down, in fact. And we won't know until the study's completed as to whether or not it's been successful, but we're certainly hopeful, as are our patients, and it's an exciting time. It's the only gene therapy trial for geographic atrophy in Australia, and the first gene therapy trial of any nature to be conducted here in Victoria at CERA. So we're super excited, and hopefully it's the first of many to come.
Thanks, Tom. And I hope everyone's getting the message that it is a really exciting time to be in eye research, and there's a whole heap of things going on at the moment. So I guess just to close out this part of the session, I'm going to ask you both what you think the next big trend is going to be in your part of eye research. So come to you first, Carla.
Sure. So in terms of devices, there are actually many international teams working on bionic eye devices and also currently in human trials. These include other retinal prostheses such as ours, and some are designed for other photoreceptor degenerations as well, including AMD, in addition to inherited retinal disease, as well as devices designed for implantation directly onto the visual part of the brain called cortical prostheses. And the other one that's also been developed are devices designed to slow down retinal cell death and vision loss at an earlier stage of disease. So electrotherapy such as this has been applied to various parts of the body in different conditions, including diabetes and Parkinson's and so forth. But in the eye, a technology to protect the neurons from dying in people with inherited retinal disease or other degenerative conditions is aimed so that they can keep the vision for longer. The other critical part of next stage development is actually combining bionic devices with artificial intelligence and other strategies in vision processing to further improve visual outcomes for patients as well. And our team is actively working on that at the moment. So I guess just to finish up, despite the amazing and huge gains from gene and cell therapies to save vision, there are still going to be people with late stage disease that do require bionic eye devices and so forth to bypass the retinal cells that are no longer working. And we're really working hard on trying to optimize those strategies with vision processing and artificial intelligence techniques to improve the visual outcomes for those people.
Fantastic. And Tom, just to close out?
Yeah, well, from the gene therapy point of view, it's just going to be more of the same. We've demonstrated that we've got the capacity to conduct trials and research here at CERA. We've got a fantastic team of researchers able to conduct clinical trials. And really, there's just an increasing number of inherited retinal diseases being targeted now. They're coming through that preclinical phase, that laboratory phase, and entering into phase 1, 2, and then 3. And we'll just be hoping to scale up, train up more people with the expert team we have at the moment, take on more researchers, and increase our capacity to conduct these studies and bring cutting-edge treatments to Australians. So I think really it's all ahead of us, and we're really just at the tip of the iceberg.
Tip of the iceberg is correct. There's a lot more to come, and that was a great conversation. Thanks, Carla, and thanks, Tom. So now it's time for your questions from home. And as we said earlier, we'll try and mention as many as we can now. If we don't get to you tonight, we'll attempt to answer offline. And just remember, we can't provide specific personal medical advice about individual cases, but we can talk in general terms. So Peter, can I pass over to you for this part?
Thanks, Keith. So we'll lead off with a question that was sent to us in advance by Chris. And Chris says, several years ago, I suffered an episode of varicella zoster, which affected my left eye. And for the benefit of the audience, varicella zoster is a virus that causes shingles that you might be familiar with. Chris goes on to say, unfortunately, it was misdiagnosed as conjunctivitis and I was not started on antiviral treatments immediately. I'm now legally blind in my left eye. Is there anything that can be done? And how is research into stem cell replacement proceeding? So in responding to this question, Chris, I first have to say that, I'm really sorry to hear this. Sadly, the virus itself can be quite a challenge to detect in its early stages, and it is well known as a bit of a masquerade of other conditions. So it can often present as other conditions. So without knowing the specific cause of your vision loss, which could be either due to corneal scarring at the clear window at the front of the eye or damage to the retina, I might turn to Ray to ask to give us a general update on how stem cell treatments are proceeding in ophthalmology.
Yeah, thanks, Peter. So as Peter mentioned, it's a little hard to comment specifically on this clinical case. So I'll comment more generally on the development of using stem cell to treat eye diseases. So for the outer surface of the eye, like the cornea, there's the limbo-epithelial stem cell, which are the adult stem cells of the cornea epithelium. This has been used as transplantation to treat the condition called limbo stem cell deficiency in clinical studies. There is now a drug called holoclay, which has been approved in Europe for the treatment for chemical injuries using limbo stem cells from the same patient. But however, this is not approved in Australia yet. Now, for the retina at the back of our eye, there's some exciting progress in using human pluripotent stem cells to generate different retinal cells for transplantation. And there are clinical trials in USA, Japan, and also UK using pluripotent stem cells to generate retinal pigmented epithelial cells for transplantation, mainly to treat macular degeneration. Similarly, there are also some early clinical trials overseas using retinal progenitor cell transplantation to treat a range of retinal degeneration. But I should point out that many of these are early trials really designed to look at the safety of the treatment. There's also an important point that I want to make, and that is there are many unproven stem cell treatments that's been advertised online, and they can potentially be harmful. So it's really important that we get our information from reputable sources. And in this case, the website for Stem Cell Australia or the National Stem Cell Foundation of Australia have really good tips and news about the development of stem cell in this regard.
Thanks, Ray. I might just dive into some of the jargon there because I know it can be a bit confusing for some of the audience. Can you just tell us what you mean by pluripotent stem cells? It sounds like a bit of a mouthful. And how where do the stem cells come from? Where do we get these cells from?
Yeah, sure. So pluripotent stem cell is a type of stem cell that have the ability to become all the cell types in the body. They can be generated from a adult stem cell source. So for example, we can now use cell reprogramming to turn a skin cell or a hair cell into a pluripotent stem cell. And this is really the Nobel Prize discovery that allow us to generate this type of pluripotent stem cells. So they're really a good cellular source to generate different type of cells, including retinal cells for cell therapy purpose.
Well, that's a very interesting thought that the future for regenerating vision might be at the end of your comb in the morning. So it's quite something to think about, that the science has taken these cells and able to turn them into other cells. Very exciting, Ray. Thanks. We might now turn to three related questions that we received in relation to retinitis pigmentosa, and these come to us from Jenny, Alison, and Cam. And I'll read the three questions in turn, and then I might turn to Tom, Carla, and Lauren for a response. So the first one is there anything on the horizon for retinitis pigmentosa? What are the advances in gene therapy for X-linked retinitis pigmentosa? And what progress is there in the treatment of cone dystrophy? So we've got three related conditions: retinitis pigmentosa, X-linked retinitis pigmentosa, and cone dystrophy. So I'll open it to the panel of experts.
Excellent. Well, I might start. So yeah, I think what you've heard today really is that this is definitely a growing field. So I mentioned before that retinitis pigmentosa is a bit of an umbrella term for different types of inherited retinal disease. And these can be X-linked or autosomal recessive. And this is referring to how they're passed down from your parents. And so that's what those different terms in the questions refer to. But there's definitely a number of clinical trials underway. There are some in particular for a form of X-linked retinitis pigmentosa that are going very well, and we're hoping to have those come to Australia soon. In addition to the gene therapy trials, there are other clinical trials, and an example is a systemic antioxidant. So this is a tablet that people can take, and that's currently being tested at CERA for a condition called Usher syndrome, where people have both retinitis pigmentosa and also hearing loss. And so there really is a lot of trials coming up now. And as Carla mentioned, obviously things like bionic eyes and other implantable devices are also options for these conditions.
Yeah, I can join on there, perhaps, Lauren. So as I alluded to a little bit earlier, in addition to the bionic eye, which is for people with the end stage condition, once they've lost the ability to see objects and so forth, we also have been working on a device that can help to slow down vision loss. So this is not yet in clinical testing, but the idea is that you use retinal stimulation, so electrical stimulation, to act on those cells and delay loss. And there's quite a lot of evidence from overseas that's looking quite hopeful there too.
Yeah, I mean, I'll just make one final comment specifically about X-linked RP. So for those who aren't familiar with that term, that means it's a retinitis pigmentosa caused by a spelling mistake on a gene on the X chromosome, and that, because men only have one, tends to affect men more severely, although occasionally females, given they've got two X's, generally aren't as severely affected, but that's not always the case. And we are in discussions with a team who would like to conduct a clinical trial for one of the most common causes of X-linked RP here at CERA. So that's exciting. And from Lauren's side of things, we're very interested in X-linked inherited retinal diseases. So, from the point of view of natural history studies. So there's a big focus at the moment on female carriers of X-linked disorders, because we want to know if some of them may be eligible or may benefit from gene therapy. And then in terms of cone dystrophies, similarly, we're in discussions with a team who would like to conduct a clinical trial for one of the most common causes of achromatopsia and cone dystrophy here at CERA. So, we're in contact with all the big major players of these common inherited retinal diseases, and they're hearing about the good work we're doing down here at CERA, and they want us to conduct trials, which is great for us, and obviously it's fantastic for our patients.
Brilliant. And I think we've heard the message that the best way to position yourself, should you be affected by one of these diseases, is contacting the team and considering joining in for the natural history study. I've got a related question from Anne, who says that I'm in my 60s and I have retinitis pigmentosa. Is there anything practical I can do to slow down the loss of sight? Tom, did you have a response to that one?
Yeah, it's a tricky one. I get this question a lot, actually. I mean, the good news is if you're in your 60s and you're thinking about slowing down the progression of RP, I mean, that would hint to me that you've got a variety of RP that's been relatively slow to progress, which is fortunate. That said, you want to hang on to what you've got as best you can. Probably the first thing you can do is try and work out what the gene is. Now, that's not obviously going to directly slow the rate of progression, but it will give you an idea, if we were to compare to studied or published cohorts of other people with that particular gene mutations, that how likely it is to speed up, slow down, stay stable. So that's useful information. But then practical things to do, aside from sort of treatments that have been worked on in clinical trial setting, I mean, wearing sunglasses outdoors, there's some evidence to suggest that long-term sort of exposure to UV lights can be put a greater load on the photoreceptors. So, on a sunny day, is wearing glasses and trying to avoid being out in really sort of bright conditions without sunglasses on. The evidence on vitamin A sort of supplementation is patchy. There's no clear sort of evidence to say that it's of benefit. Probably say just a healthy, balanced diet is the main thing. If you've got some forms of inherited retinal disease, you actually want to avoid high levels of vitamin A, ABCA4, macular dystrophy being one. And just healthy lifestyle, exercise, but there's nothing specific, I'm afraid, at this stage.
Thanks, Tom. That's a very comprehensive response. We might turn now to age-related macular degeneration, and we'll start with a question which I think is directed to you, Robyn, from Vicky. Can you progress from early dry age-related macular degeneration to intermediate stage in 2 years, even without risk factors such as smoking, an unhealthy diet, or family history? And what are some innovative clinical trials to stop the progress of soft drusen?
Thanks, Peter. So I think it's time to give everyone a lesson on the nomenclature around AMD. So the way I like to think about this is there's terms called early AMD, intermediate AMD, and then late AMD. And that relates really to the stage of risk that you're at. And the difference between early and intermediate is based on the size of these deposits called drusen. And so a drusen that's 63 microns is early and a drusen that is 64 microns is intermediate. So immediately you can see that it's very easy to go from early to intermediate without not much changing in your retina. So I wouldn't get too concerned about the terms. It would be more what your retina looked like. And unfortunately, AMD is mainly related to age and your gene risk. In fact, AMD, despite having talked about these inherited retinal diseases, indeed AMD is a very well recognised complex genetic disease. So we know there are about 50 or so known changes in the genes that give you a risk of AMD. So yes, one should live a healthy lifestyle. One shouldn't smoke. They are, as what Tom was saying, potentially going to slow down progression, but it's not unusual to progress. In fact, 1 in 7 people will progress once they have the beginnings of AMD. And in terms of treatment trials, you may have gathered most of the big pharma companies are involved in trying to slow down progression once you've already got a major problem, late AMD. Whereas our own work has been exactly as you ask, how do you slow going from these earlier stages to the late stages? And unfortunately, there's not much activity around because it's very hard to design a trial that will enable you to work out whether you've been successful. But as I was saying before, we actually sort of lead the world in understanding that. And indeed, we've had a very successful trial of a Australian-made nanosecond laser that aims to slow the progression of the disease. And we're in the middle of talking to the FDA in America to repeat that trial to validate it in America. And we already have a second laser trial with a different laser from South Korea. So we're very actively recruiting currently people with what are called intermediate AMD, so slightly greater risk than the smaller drusen, to see whether we can slow the progression. Interestingly, there are different sorts, like as Lauren was saying, RP is this umbrella term, or AMD is an umbrella term for a whole lot of different bits of AMD. And so the laser treatment seems potentially to be useful for most AMD, but not all. And so we're repeating some of these studies now currently. So if anyone has what's called intermediate AMD or high-risk early disease, we're very keen to see people to enroll in our trials. And probably once we find a treatment for geographic atrophy or dry late AMD, we'll probably start to use those earlier and earlier. And so once we find something that works later, you might be very interested to try it a bit earlier. So I'm hopeful that if we find treatments that can slow down the growth of dead cells, then we might be able to start early and stopping them in the first place.
Wonderful. Thanks for that very comprehensive answer, Robyn. And you've addressed, I guess, much of the questions that have been posed by David and Jan. One aspect that I might ask you is, what are the latest developments for treatment for wet macular degeneration? We've heard a lot about early, intermediate and dry. What about the wet form of the disease?
Maybe I could just tell you about wet and the late form of dry geographic atrophy. Apart from gene therapy, there are other trials based on genetics. So the complement pathway was first implicated by looking at the genes. And so there are a lot of trials in geographic atrophy trying to dampen down inflammation as a result of the complement pathway. But in terms of wet AMD, we have, we've developed what would be called a miracle. We've stopped people getting severe vision loss very quickly, but we haven't really stopped people slowly losing vision. And so the quest in neovascular AMD or wet AMD is to have a longer acting drug so that people don't have to have these injections in their eyes so frequently, and to try and stop the progression to cell loss that still occurs even though you stop the bleeding, and indeed the scar formation. So there's still room to improve the outcomes, even though we've done a terrific job in stopping legal blindness, treating wet AMD with our current injections. We still need to find a longer acting one because people are undertreated because they cannot access the treatment for a variety of reasons. And even if you can, you still end up with not such great vision due to cells dying and scarring.
Great, thanks, Robyn. And just a personal anecdote around the rate of change in this field, and particularly in relation to wet age-related macular degeneration. When I was doing my PhD in the early 2000s, I was almost laughed off the stage when I suggested that there was an injected therapy that was going to transform the disease just around the corner, and it's now 13, 14 years since, and it's really transformed our management of this disease. So I think that helps to ground what we're hearing about the next wave of treatments with this gene therapy technologies we've been talking about tonight. Keith, I might turn to you with some questions in relation to glaucoma. And so we have some questions from Cheryl, Sonia and Luba, and that they're related. So I might group them and then seek your response. So is there hope for people with glaucoma who already have optic nerve damage? And then a related question is, I have glaucoma and still have a little bit of central vision left. Is there a chance that the optic nerve can be repaired?
Well, Peter, those are great questions, and those are the exact topics that my research is really focused on at the moment. In terms of optic nerve repair, I think there is real promising evidence that we can do this, and we can do it in animal models already, believe it or not. So we work with models where the optic nerve has had traumatic injury, and that does not normally repair. So normally when the optic nerve is injured in adults, it cannot regrow. But what we find is that there are ways that you can help it to regenerate and grow back to the targets in the brain. And we've been exploring a number of different pathways. There's a molecule called protrudin, which can help this occur, and we've been delivering that by gene therapy in animal models. Now, this is not at the clinical trial stage yet, and we don't even know whether it will be able to restore useful vision. It does restore some visual responses in animals, but we don't know whether it will be useful vision. So that's a caveat at the moment on that. I think there are other things you can do, and again, we've done a study recently, and this was work of Jonathan Croston and Flora Hui from CERA that's kicked all this off. And Peter and I have been involved as well with vitamin B3, and vitamin B3 can be used to treat a range of different conditions. It's been explored in a range of different conditions, and what this clinical trial that we did showed that it could actually improve some measures of visual function in patients with glaucoma. Now, it wasn't a dramatic improvement, but it was a detectable improvement in a short study. And so we're now about to start a much larger study over a much longer period of time to see whether this can, at worst, improve best improve the vision, but at least stop or slow the decline in vision when added to conventional treatments. So those are some of the things we can do. I think that we will have strategies that will improve visual function. I think we're still quite a way from regenerating the nerve back to the brain in a way that restores useful vision, but we're starting to be able to do this, and we can certainly get the nerve fibers to grow back to the brain. But there's a lot more to the problem that we haven't quite cracked, but that's what keeps it interesting.
Fabulous. Keith, I know you're not a betting man, but I might ask you to make an exception in this one instance. What would you say is the timeline for a gene therapy for glaucoma to reach the clinic?
So I think we'll be starting clinical trials of gene therapy, either our group or others, within the next year to 18 months. So that's the sort of time. I think somebody will have got there to the starting line within that time. The trials themselves then take about 2 years, say two and a half by the time that you've recruited and followed the patients up. So you're looking at, if those trials are successful, and there's a lot of ifs in there because we don't know. That's the whole point of clinical trials. They're not just a rubber stamping exercise of a new treatment. They're to actually demonstrate whether or not that treatment is of benefit. And so you don't really know until that stage. But I think getting to the clinical trial stage within the next 2 years, conservatively, is extremely possible for gene therapies for glaucoma.
Wow. Fabulous. So I'm just quite mindful of the time. We've got one other question that was sent in advance, and I know that there is a roll call of additional questions that we'll deal with offline, but I'll just deal with this last one that Cheryl sent in. And Cheryl was asking for an update on LHON research. So I might field this one. So LHON, for those of you that don't know, is Leber's hereditary optic neuropathy, and that's a hereditary condition caused by a change in the DNA of the mitochondria, so the instructions of the mitochondria. And those mitochondria are the small energy factories within each of our cells. And Isabel Lopez Sanchez is one of our local experts in LHON, and she's principal investigator of our mitochondrial biology and disease unit. So Isabel was kind enough to provide me with a summary of what she sees as some of the sort of hot areas in LHON research. And Isabel's very modest, but I did pressure her to highlight some of her research. And I must say that the team's really accomplished a great deal in recent times. They've just finished a comprehensive nationwide audit of Leber's hereditary optic neuropathy in Australia. And they found that there are 96 families affected by the disease across the country, and 355 people who currently have vision loss due to the condition. Isabel's team has identified 5,000 people who have a LHON mutation. So this is that spelling error in the mitochondria. So these are people at risk, but who are asymptomatic. And so this is obviously an important bank of individuals who might benefit from research as there are further developments. Isabel's team has recently published this research in a prestigious journal. And that is going to be made freely available online in November. So keep your eye open for that. At the moment, one of the challenges is that it's impossible to predict which people who have the risk factor, so the mutation for LHON, will go on to lose vision. And so you can imagine that this uncertainty is tremendously challenging for individuals who are carriers of that spelling instruction. So Isabel's research is actively trying to understand why some people lose vision with this mutation and why others preserve good vision throughout their lives. And she's currently trying to identify genetic risk factors that are predictive of vision loss, and that may well lead to the development of a gene therapy to protect against vision loss. Finally, Isabel was very keen to highlight that individuals with LHON who experience vision loss may be eligible for compassionate access to an experimental drug called Raxone or idebenone, and that's shown some promise in clinical trials, and it's been available for some years in Europe. So that can be accessed through a special access scheme via your ophthalmologist. So that's just something else to keep in mind. So with that, I'll wind up the question and answer section. I'd like to thank all of our panelists for your contributions. And so I'll invite the audience to join me in a virtual round of applause. Oh, that hasn't worked. There you go. A virtual round of applause for our panelists. Back to you, Keith.
Thanks, Peter. It's been a great session, a great conversation. And I'm really grateful for the enormous interest that's shown in our research and the opportunity we've had tonight to share it with you, our supporters. If you just tuned in, this session is being recorded and you can watch it again on LinkedIn or on Facebook, or I think also on the CERA website. And if you're interested in learning more about the latest research at CERA, I encourage you to visit our website. We had a major refresh of our website over the last year or so, and you should find it very easy and clear to navigate around, even if you have reduced vision. That's cera.org.au. So finally, as I mentioned earlier, our Hope Insight Giving Day kicks off immediately after we finish tonight, and we're again aiming to raise $150,000. And for every dollar donated, that will be tripled by our generous partners at the National Stem Cell Foundation of Australia and the CERA Foundation. So triple your money towards the research, which I think is really great, and we thank them for their support as well. So if you're watching and keen to donate, you can do so at charity.com/hopeinsight, all one word. And that's charity with a D, not a CHARIDY.com/hopeinsight. So we're all here because we really do want to make a difference to people living with vision loss and blindness, and that's our motivation to keep our research going. And it's why we come to work every day, I guess, everybody on the panel tonight, to try and get these treatments through. And this year we have a face for the campaign, and it's 22-year-old Billy Morton, who is sharing his story of living with choroideremia. That's something we didn't talk about tonight, but something, again, where gene therapy is being developed. It's another important cause of inherited eye disease. And we're really using Billy's story to highlight the importance of vision research. And so I think it's fitting that we sign off with his story tonight. And a big thank you to Billy and his family for supporting our campaign this year. And thank you for attending tonight and for your continuing support of eye research. So over to Billy. Thanks again.
I'm Billy, and I'm 22 years old. So I live with a rare genetic eye condition called choroideremia.
Billy was diagnosed in his early teens. There was a possibility because it is in the family and his cousin had already been diagnosed earlier on, but it still did come as a shock to us.
I think over time, as choroideremia will progress, it'll make it harder and more difficult for me to do things that I've become used to doing.
Billy is a really positive person, and he's got a very strong outward view on exploring and wanting to live life. We do hold hope, though, that obviously that with research that we'll find opportunities that we'll be able to maintain his vision at a certain level that allows him to continue to do that for the entirety of his life.
The research is very exciting at CERA, and I think not only just for myself but also for many people who are affected by vision loss or blindness.